All right, team, I have a little after one. We're going to go ahead and get started. Thank you for joining us this afternoon. It's another one of our lectures in the Penn Rescue Lecture series. We're lucky to have Mark Seamon, professor of surgery here at Penn, talk to us this afternoon. Mark is an expert in many things. He's our head of research and education for our division, has a long history, though, in penetrating trauma, ED thoracotomy between all of his time at Temple University and here on this side of the city at HUP and now at Penn Presbyterian Medical Center. He's studied this challenge of vascular trauma a little bit more so in penetrating than blunt, but he's going to give us a nice overview of the changing landscape in vascular trauma. Mark, thank you very much. I'll ask everyone to please mute your microphones and put all your questions in the chat. Dr. Seamon will make sure to go through the chat as this ends and answer all your questions. Mark, thanks a lot.
All right, good afternoon, everyone. It's an honor for me to speak today, and thank you, Pat Riley, and really the entire marketing team who helped set this up. I'm going to speak about a topic that's undergone significant change over the past couple of decades, and one, like Dr. Riley said, that's a special interest to me, the management of peripheral vascular trauma. And this is one of the big reasons why, to understand vascular trauma, at least in Philadelphia, it's important to appreciate its context and setting. The vast majority of vascular trauma here is caused by firearm injuries. So if you want to, help save these patients and help gunshot wound victims, this is really a great way to do it. Extremity vascular injuries are relatively rare in all but the busiest urban trauma centers, which, as this, I think, really shocking heat map shows, clearly we're one of those. For us in the trauma world, these vascular injuries lead to rapid exsanguination and death if they're not quickly diagnosed and treated. And really, it's this very combination of uncommon injury at many trauma centers and rapid and profound blood loss that continues to challenge those of us who manage these injuries. They're completely unforgiving of any real operative missteps, so it's important to stay kind of on top of new data and new and potentially better ways of managing these tough injuries. We're going to talk about some contemporary issues in vascular trauma that I think will help us manage these challenging patients, perhaps just a little bit better. The first area to discuss is in the diagnosis of vascular injuries. And to really kind of appreciate the new, I think we have to talk about the old and historic. In fact, born from World War II data, really all injured extremities with potential vascular injuries mandated operative expiration. But soon we realized that this led to excessive non-therapeutic expiration rates and significant morbidity, but it did sharply decrease amputation rates from untreated major vascular injuries. Soon, clinicians became a little more choosy and discerning and limited surgical explorations to those with exam or diagnostic adjunct findings. Clearly, time to diagnosis, control, and reestablishment of blood flow impacts outcomes. So whatever additional tests are needed, they better be rapid. Physical exam findings such as hard signs of major vascular injury are reliable and often don't require further study prior to operative exploration. And those without hard signs, though, ABIs, as depicted here in the image on the right hand of your screen, further increase your diagnostic sensitivity. Is about 10% of patients with injuries requiring surgical repair will still have palpable pulses. Other modalities can be helpful, but take time. Duplex ultrasound is fairly accurate in detecting vascular injuries, but usually requires a technician. Oftentimes this is at night, and it takes significant time. Conventional arteriography is similar, although it's less invasive than operative exploration. It still carries a 1 to 3% risk of morbidity and delays definitive operative repair. So for the remainder of the diagnosis portion of this lecture, I'm going to talk about what I think has become really the diagnostic adjunct study of choice for peripheral vascular trauma in modern times, the CT angiogram. And to do that, I'm going to discuss a study that we started and completed locally here in Philly about 15 years ago, overlapping with my time as a surgical critical care fellow right here at Penn. At the time, we hypothesized that CTA would provide the same injury detection capabilities as more invasive conventional arteriography, but in a rapid and cost-efficient manner. Before this time, previous reports had compared the two modalities, but they were either retrospective or they lacked a study control arm for true valid comparison. We did this by comparing extremity vascular injury detection capabilities of CTA to the gold standard at the time, conventional arteriography, or operative exploration for each and every patient, unlike the usual control group comparison where you kind of say, well, the patient didn't come back with an ischemic limb, so they're probably okay, and CTA is an effective diagnostic tool. It was a prospective study over a 1.5-year period and included those with either upper or lower extremity blunt or penetrating injuries and an ABI in the injured limb of less than 0.9. Patients with hard signs underwent immediate operative exploration, while those without hard signs underwent ABI determination. Patients whose ABI was less than 0.9 in the injured extremity were enrolled and underwent both CTA and then an immediate confirmatory study of the injured extremity. Patients with limb-threatening vascular injuries underwent immediate operative exploration. So in these select patients, only CTA findings were confirmed by operative exploration instead of conventional arteriography. CTA studies were interpreted by an attending radiologist, and conventional arteriograms were separately read by an attending interventionalist who was blinded to CTA findings before performing and reading the conventional arteriograms. Primary study endpoint was the official radiologist and interventional radiologist reads. Overall, 18 CTAs were confirmed by conventional arteriography, 2 were confirmed by operative exploration, and then 2 were confirmed by both arteriography and operative exploration. Perhaps the most important finding, sensitivity and specificity of CTA for the detection of clinically significant extremity vascular injury was 100%. And important to avoid diagnostic pitfalls and treatment delays and things like that. Unlike rapidly obtained CTA, conventional arteriography required on average 131 minutes to complete. So with 100% sensitivity and specificity for injury detection and rapid availability, CTA replaced conventional arteriography as a diagnostic study of choice for extremity vascular injury detection in most clinical scenarios. Now, as I alluded to, for years we managed patients with potential peripheral vascular injury as depicted here. Those with hard sides went to the OR, those without had ABIs performed. Patients with normal ABIs were sent home, and those with ABIs less than 0.9 underwent CTA imaging, with the next steps determined by the CTA imaging results. But I'll tell you, over the years, we have appreciated several caveats to this rather simple algorithm. And the first is upper extremity injuries. There's an extensive network of collateral vessels around the shoulder that make both your physical exam pulse checks and even your ABIs less accurate for injury detection. Now, I know what many of you are thinking, an extremity is an extremity. And if an ABI works on a leg, it should work on an arm, because I thought that exact same thing when I came back to Penn in 2014. So we did what any academic trauma surgeons would do, we studied it to prove that we were right. And this was an 11-year study from Penn, Temple, and Grady, looking at penetrating upper extremity injury patients who had documented APIs. What we found was, I think, fairly striking. In 218 patients, the sensitivity of screening APIs was somewhat poor for injury detection, ranging from 60 to 69%. Now, if we remember our stats, what does that really mean? It means that only 60 to 69% of patients with an actual upper extremity vascular injury will have an API less than 0.9. So quick and harmless to the patient, but not great as a screening test. And this was true regardless of vessel. So it wasn't like we were detecting a bunch of ulnar artery injuries on CTA, but using radial artery to measure APIs. So we were proven wrong, but this is exactly why we do research, even simple studies like this one. Now, humbly, will routinely CT angio any patient with potential peripheral vascular injuries of the upper extremity for these exact reasons. Speaking of branch vessels, the second caveat I want to mention is below knee penetrating injuries. With 3 vessels running to the foot, clearly you can have injuries to major named vessels with an intact pulse and abnormal ABIs. Injury to these can lead to significant hemorrhage, compartment syndrome, or even rarely, but limb loss. So this is another area that I'll routinely CTA without other indications such as screening APIs. As we continually look to refine our care, the last algorithm caveat I want to mention is profunda injury, which unfortunately it seemed to have my very own case series. Again, pulse checks and ABIs won't diagnose a profunda or branch injury. These are 2 different patients here, and both had thigh gunshot wounds, intact pulses, no hard signs, and normal ABIs. One was sent home without imaging and returned after nearly exsanguinating from his wound, literally using his own leather belt as an improvised tourniquet, and came back in. And the other, thankfully, was imaged based on potential trajectory through the profunda region, and the injury was promptly recognized and treated with IR embolization by our radiology colleagues. So this is what our now slightly modified diagnostic algorithm looks like today, with the additional dotted line representing each of the caveats and diagnostic refinements that we just mentioned. As you can see, we now more aggressively use CTA than our original algorithm suggested. Another aspect that's changed in recent times that I feel I would be remiss if I didn't at least mention, we're seeing nearly double the number of gunshot wound victims that we did just a few years ago. And 2022, once again, is on par with 2020, 2021. In fact, the pandemic seems to have established a new norm where not only we have major vascular injuries become more common, they're more commonly caused by gunshot wounds. Unfortunately, newer types of ammunition have also been developed. This is one that I've seen several times, including just last week, in a sad and not so subtle play on words. These are called RIP bullets, which stand for radically invasive projectiles. These are a type of hollow tip bullet that have a solid core, but then are surrounded by smaller copper trocars that fragment off upon impact, creating 9 different penetrating injuries within the body cavity. In the lower left of your screen, you can see this patient was shot 3 times by RFP bullets, once in the left hip, once in the left thigh, and once in the right knee, and each of those splintered into several different fragments. In the lower middle and right, this is a CT angio we did of the patient's right lower extremity. The middle is a standard CT angiogram with a retained bullet core, which, as you can see, creates significant streak artifact, and it's very difficult to appreciate if there's any subtle injury, such as an arterial dissection to the adjacent popliteal artery. But then in the lower right, we use a new CT scanner post-imaging software called MAR, or metallic artifact reduction. And now we can clearly see that the popliteal artery is uninjured. There's no need for either operative exploration or conventional arteriography to look at the vessel. So the next innovative area to discuss in vascular trauma is a particular treatment for the particular injury location, the endovascular repair of axillosubclavian artery injuries. Nowadays, endovascular repair has become the primary treatment modality for many vascular surgery problems. Does this apply to vascular trauma? Well, of course it does. As much as I enjoy doing open repairs on injured arteries, there are particular injuries that are simply better suited to endovascular repair, and it's essential to recognize these quickly. Though uncommon, rapid operative exposure of the subclavian and proximal axillary artery injuries is really especially difficult in the exsanguinating patient. Periclavicular incisions are accompanied by extension into the neck, the chest by median sternotomy or thoracotomy, as seen here on the left, or require clavicle resection, as seen on the right, for adequate exposure of these areas. These are large, very morbid incisions. Vessels are surrounded by vital structures, making quick dissection difficult and prone to mishaps in patients with hematomas and distorted anatomy. Is there a better way to do this for this particularly difficult to access injury complex? Well, this is the dream and hope for these patients. Diagnose the axillosubclavian injury with CTA, get a wire across it, put a stent up, and reestablish flow in a hybrid room without the need for large morbid incisions. Now let's talk about some of the data supporting this new approach to this particular injury location. One of the studies we'll discuss is one of the first on the topic, and it's from none other than Ken Maddox. This was a 2-year retrospective review from Bentob that included blunt or penetrating subclavian artery injuries. And the report is very typical of initial series in that there really isn't much you can say except that, in fact, this can be done. The series included 15 patients, of which 5 died in the ED and 8 were taken directly to interventional radiology from the trauma bay. Each of these 8 had initial attempts at endovascular management. 2 had minor injuries that didn't require any intervention. 6 underwent endovascular repair, 4 of which were successful. Of course, we have no long-term patency data or even long-term survival data following hospital discharge. But based on this early experience, they changed their treatment paradigm for these difficult to access injuries. Now, patients with subclavian artery injuries and adequate hemodynamics were taken to the interventional suite rather than the operative suite. This was really a huge paradigm shift at the time. Study questions become a bit more nuanced a few years later. Instead of asking if we can repair these injuries using endovascular techniques, we begin to ask which patients should get endovascular repairs and what are their long-term outcomes. It's important that we don't forget trauma patients are often young and healthy and very different than most typical vasculopaths. The authors report a variety of data regarding axillosubclavian injuries from the NTDB and found clear indication trends. Endovascular repairs were performed more often for blunt vessel injuries, while open repairs were reserved for penetrating injuries. And when you really think about it, this makes perfect clinical sense. Blunt injuries are often lead to thrombosis, while penetrating injuries more often lead to free bleeding and exsanguination. Then the authors included additional data from their own institution for these injuries, although very limited with only 10 patients reported here. Some long-term data was described, and what they did reveal was really not very promising. As typical with many long-term trauma studies, 70% of these patients were lost to follow-up at 4 months, and 3 of the 10 stents thrombosed.
Hey,
Final study
quick
on the
question for
topic.
you. I'm trying to get some stuff uploaded to finalize the ANCC annual report.
Can you mute your mic,
Did
please?
we? I know we did the endo last year. We did the 100 years of insulin therapy.
Thank you. That question wasn't for me, was it? I don't think so. Anyway, final study on the topic. This was a retrospective one from 11 different U.S. trauma centers. The authors looked at several different measures, but most fascinating to me was the open versus endovascular clinical variable comparison between the two study groups. A few findings or lack thereof are really striking here. First, there's absolutely no physiologic data reported. To me, this is perhaps the most important determining factor in the open versus endovascular decision. Aside from that, endovascular repairs are being utilized more often for subclavian rather than axillary artery injuries, and those with minimal injuries and pseudoaneurysms, while open procedures are reserved more for the more distal axillary artery injuries, significant circumferential injuries, or complete transections. And this is a very nice algorithm they suggest. Patients with soft signs of vascular injury undergo either CTA or conventional arteriography, really depending on hemodynamics, while those with hard signs consider proximal balloon occlusion in the OR for those in shock. This kind of hybrid approach is something that I think is particularly well suited to these injuries. As we've already said, they are not readily accessible through open incisions. So the obvious question is, what method of repair to do when for these challenging injuries? I put this summary table together. Hopefully it'll help highlighting the most important factors in my opinion. Obviously, I'm a trauma surgeon. I'm not trained in endovascular therapies and clearly need the assistance of either interventional radiology or my vascular colleagues. So my default will always be open repair. But even with these biases in mind, open repairs are still more often performed today and perhaps better suited for penetrating injuries, full thickness injuries, injuries with free bleeding and resulting hemodynamic compromise, and then those with contraindications to anticoagulation. Now, despite these data and indication shortcomings, endovascular therapy has been steadily increasing for peripheral vascular trauma since really the turn of the century. Now, if the number of peripheral vascular injuries remains relatively constant in the country, not necessarily Philadelphia, but overall in the country, and endovascular repair rates are increasing, then clearly the number of open vascular repairs must correspondingly decrease. In fact, this phenomena has been occurring for 2 decades and represents a new but significant challenge to all of us taking care of these rare and difficult injuries. Switching gears again, but continuing on with the topic of free bleeding due to vascular trauma. For the remainder of this lecture, I'm going to talk about one of the best methods that I know of to reestablish blood flow and limit blood loss in a patient with critical vascular trauma, and that's the use of the temporary intravascular shunt. Once again, I think it's important if we were to appreciate the new to have an appreciation for the former and historic. Once again, the history of shunts is intimately associated with that of combat vascular surgery. Around the turn of the 20th century, military surgeons began to recognize that arterial ligation led to poor outcomes and looked around for ways to quickly restore perfusion. Now, interestingly, early attempts at arterial shunting were not actually temporary, but permanent. And the theory at the time was that these permanent tubes would thrombose, but the hope was that they would gradually occlude and collateral circulation would develop. In 19 22, Makins provided the first wartime description when 2 tubes were utilized for arterial injuries during World War I. And then a few decades later, lightweight alloy Vitalium tubes were out by the Office of the Surgeon General, and used actually in over 40 combat cases during World War II, when the average evacuation time was then over 12 hours. But really, Eager provided the first true and modern detailed description of temporary intravascular shunts used to treat combat injuries in Israel in 1971. Then, due to body armor and the preponderance of extremity injuries seen during the military conflicts of Iraq and Afghanistan, TIVs use really became much more widespread, as did data supporting their use. The 2 primary indications for temporary shunt placement are combined orthopedic and vascular extremity injuries, and for damage control reasons. There are others described, but these 2 comprise over 95% of the reported indications in the literature, so we're going to focus on those 2 today. Let's start with combined orthopedic and vascular extremity trauma. The common board scenario type answer to this clinical situation is to reestablish blood flow with TIVs, followed by rapid external fixation by orthopedics before finally completing the definitive vascular repair only after the limb is fixed in a rigid position to prevent repair disruption. Although this really makes perfect clinical sense, data supporting this clinical sequence is very limited. First things first, this is from a very recent Journal of Trauma issue. Should we reestablish blood flow or fix bones first? I know what the orthopedics would say. I believe this came out this month in the Journal of Trauma. This is a simple single-center retrospective study looking at patients with combined long bone extremity fractures and major arterial injuries. And then patients were then compared with respect to long bone fixation timing, either pre-vascularization or post-vascularization. I think it's important to realize, though, fixation could indicate either X-fix or ORIF, and revascularization was defined by either shunt or definitive arterial repair. The time to revascularization, I think, was fairly long in both groups, but nearly double the elapsed time until revascularization in patients who had underwent long bone fixation prior to revascularization. So fairly telling. And this really appeared to impact measured outcomes as well. Those that underwent bony fixation prior to revascularization were over 6 times as likely to undergo later amputation and 4 times as likely to sustain graft failure than their post-fixation counterparts. Now, this is the most detailed and perhaps best data available to date that I know of. This is a retrospective multi-center review from 6 level 1 centers of patients with combined orthopedic and vascular extremity trauma. Study groups were compared on the basis of intervention sequencing into 3 groups: TIVs prior to orthopedic fixation, and then revascularization, revascularization before orthopedic fixation, or orthopedic fixation before revascularization. Overall, 291 patients were analyzed here. And then when these studies groups were compared, there were some interesting findings. There were a few different comparisons here. The shunt group was compared to the no shunt group on the right side of your screen. And then the no shunt group was further divided into revascularization or fixation first groups, which you see on the left. There's some noteworthy findings. Although the limb AIS and MES scores were greater in the shunt group, the ischemia time in the shunt group was roughly half of that in the no shunt group. Was the ischemia time associated with outcomes? Well, it appears so. Only 15% of the shunt group developed compartment syndrome, while 34% of the no shunt group developed the same. Then when we look specifically at the no shunt group, 20% of those who underwent fixation before revascularization required amputation, compared to only 7% in the revascularization first group. Then finally, what if you look at shunt versus revascularization first group comparisons? Now, with shorter ischemia time, less compartment syndrome, it still seems that TIVs offers benefit over revascularization first strategies. So that's the best current data supporting the role of TIVs in combined orthopedic and vascular injuries of the extremities. What about its role in damage control surgery? I really consider this the primary and most exciting application today. And I'm not just saying that because we're in the home of damage control surgery. The components, though, are well described and call for an abbreviated initial procedure. Well, the focus is on rapid control of hemorrhage and contamination. The formal repair then is undertaken after a period of resuscitation. Shunting fits very well into these management principles. It allows for rapid hemorrhage control of the exsanguinating vascular injuries and allows for restoration of distal perfusion. So how do you correctly place a temporary intravascular shunt? After obtaining proximal and distal control, systemically heparinize if you're able, and Fogarty thrombectomy, both proximal and distal ends of your injury. Prepare your shunt by marking the middle with a tie so you can see if it later migrates, and then clamp the middle. Place shunt end about 2 centimeters in the proximal end, bleed the vessel, and then reclamp. Next, bleed the distal end and thread the distal end of the shunt in 2 centimeters, securing the shunt in the vessel by tying near the vessel ends. I like to prevent dislodgement by leaving one long tail on each of these ties and then tying them together. If there's a long gap, this is another version of that exact technique pictured here. Next, you want to confirm distal flow either by pulse or Doppler. We'll discuss the role of potential systemic anticoagulation during the shunt dwell period. Although I do not routinely anticoagulate during the dwell period, I do bleed both ends again, systemically heparinize again, and Fogarty again before the definitive repair. There are many types of shunts available to you. If we go clockwise, I personally like the simple plastic argyle shunt seen here in the top left corner. But Sunt shunts in the top right, Pruitt and O'Hara shunts are also available in the bottom right. And then, of course, chest tubes trimmed down to the proper size are often best suited for large veins or artery injuries of the torso. Of course, proper technique and choosing the correct shunt type are important in preventing shunt complications. There are several well-described shunting complications, and they collectively occur in about 25 to 30% of procedures. Common ones include vessel intimal dissection or damage during placement, often from attempting to use too large of a shunt. Shunt migration or dislodgement, we mentioned a few of the techniques to prevent this complication. Excuse me, and then finally shunt thrombosis, which of course may limit distal perfusion. Several clinical variables are important to outcomes after TIVs placement. We spoke of technical aspects of the placement. There are also several variables predicted of shunt thrombosis. Small caliber shunts and distal vessels are prone to thrombosis due to decreased flow. Same decreased flow is seen in various shock states as well, all perhaps precipitating shunt thrombosis. Management of concomitant vein injuries is also important. Ligated veins impede outflow and may eventually lead to impaired flow through the arterial shunt and impaired inflow. Same is true with compartment syndrome and shunted extremities as well. Poor distal outflow leads to poor flow through the shunt. And then finally, we're going to discuss two of the more controversial clinical variables: the use of systemic anticoagulation during the dwell period and the shunt dwell times themselves. Let's talk first about the use of systemic anticoagulation during the shunt dwell period. This decision is often not a straightforward one. Clinician must balance the risk of shunt thrombosis and possible ischemia or amputation with the risk of potentially fatal bleeding that can be associated with systemic anticoagulation in what are often multiply injured patients. Again, if you're looking for data to guide your decision, I would say that evidence is limited once again. This is one of the largest civilian series that's been published to date. It was a multi-center review from 7 American level 1 trauma centers of all patients who underwent TIVs placement for any traumatic injury, regardless of vessel or location. The 201 study patients, about 2/3 were placed for damage control indication. 3/4 were placed for extremity vascular injuries. Although 22% utilized systemic heparin during the dwell period, fewer than 6% of shunts actually thrombosed. And in the multivariable logistic regression model, there was really no association between systemic heparinization during dwell period and shunt thrombosis. What if we look at other contemporary TIV series from the past 2 decades? It turns out the INABA report we just spoke about had the highest systemic heparin utilization rates of these series. Many didn't utilize systemic heparin at all during the dwell times. Also interesting, there seems to be no association with need for amputation, which, really in the end, that's perhaps the ultimate endpoint regarding utility of heparin. In fact, the longest reported shunt dwell time, to my knowledge, was 10 days, and that was without anticoagulation. Another controversial aspect of temporary intravascular shunts is the dwell time itself. Many series describe extended shunt dwell times for several days without adverse events. But, as always, just because we can leave a shunt in for extended time does not mean we necessarily should leave a shunt in for extended time. So in this regard, we undertook a retrospective review from 2005 through 2013 of all patients who underwent arterial shunting for traumatic injuries. Patients who were less than 15 years of age or had injuries distal to the brachial or popliteal arteries were excluded. When analyzed by shunt dwell time, the times overall were relatively brief. 57% of patients had dwell times under 6 hours. 95% had dwell times less than 48 hours. These were high-grade arterial injuries with a median AIS of 4. Venous ligation and fasciotomies were common, as was hypotension and the use of pressors. 17% of patients died before hospital discharge, including 7 patients who expired before shunt removal. With these 7 patients excluded, the 5 patients who developed complications were compared to the 30 that did not. There are no differences with respect to age, injury mechanism, blood pressure, associated injuries, such as vein injuries. Similarly, there were no differences in the AIS of the injured arteries, rates of major venous ligation as a method of managing vein injuries, hypotension, or use of vasopressors. Systemic anticoagulation wasn't used in either group. However, 100% of those with shunt complications had dwell times greater than 6 hours, where only 37% of those without complications had dwell times greater than 6 hours. With a p-value of 0.01, this was a significant finding. But stated another way, none of the 19 patients with dwell times less than 6 hours had shunt complications, but 31% had complications with dwell times greater than 6 hours. Last study we'll talk about today, and this is another very recent one, I believe, again, either this month or last month in Journal of Trauma. This is a systematic review looking at temporary intravascular shunt use in both civilian and military settings. They combined outcome data looking at the need for fasciotomy, development of compartment syndrome, shunt thrombosis, need for amputation, and mortality. And I'll tell you, one aspect is very neat. Of the 12 civilian shunt studies to date, we here at Penn Trauma either contributed data or the primary investigation center for 4 of the 12. These studies supplied over 2/3 of the study subjects on the topic. So that was pretty neat. Overall, what did it show? Over half get fasciotomies, 10% or less develop compartment syndrome, shunt thrombosis, or need for amputation, while 16% died, no doubt due to the very critical injuries and necessitating shunt placement in the first place. This figure is a great summary of the things we talked about and offers a very up-to-date perspective on shunt use today. If you cannot perform immediate definitive vascular reconstruction because of orthopedic fixation is required, then shunt, X-fix, and then do your definitive vascular reconstruction. Now, if you cannot perform immediate definitive vascular reconstruction due to physiologic compromise or hemodynamics, then shunt, resuscitate, and then do your vascular reconstruction. And finally, if technical expertise is unavailable, shunt and transfer out to definitive care as needed. Hopefully some of these newer approaches and data discussed today will help in our quest to better care for these critically injured patients. I tried to squeeze a lot into this 45 minutes, but to review, a combination of physical exam, ABIs, and CTA is a rapid and accurate way to diagnose peripheral vascular injuries. Endovascular stenting should be considered for difficult to surgically access axial subclavian artery injuries with favorable hemodynamics. And then finally, temporal intravascular shunts are very useful in combined vascular orthopedic injuries, damage control, and critical injury scenarios. Thank you all for your attention, and love to hear some questions.
Yeah, thanks, Mark. If you can unshare and maybe you can look in the chat. I got boxed out of the chat. And while you're doing that, could you maybe just comment a little bit on venous extremity trauma? You know, should those be repaired? Should they be ligated? Is there ever a role to shunt one of those if somebody's got a combined arterial and venous injury and you're going to be back later and both, you know, just to increase outflow?
Yeah, I think that's a great question. Thanks, Dr. Riley. There certainly is a role for both venous repair and venous shunting, although I will tell you we don't have a great experience with venous shunting. Because of the lower pressure, pressure through the shunt, they're more prone to thrombosis. But the hope is it does provide some outflow over the day or so after injury. In terms of venous repair, yes, I think anytime venous repair is an option rather than ligation, I would opt for venous repair, especially with a concomitant arterial injury, again, to try to improve that outflow. Sorry, I'm just looking for the chat.
Mark, I don't see chat. I don't know if that's disabled.
I don't either.
All right. Well, I'll figure that out. How about Mark? Where do you fall these days on prophylactic fasciotomies in patients with extremity trauma? Is that something that we used to talk about, and now that we're old and have gray hair, we don't need to do anymore, or should we still be doing it?
Yeah, we just submitted our experience to AAST, a large prospective multi-center study looking at or comparing prophylactic versus therapeutic fasciotomies, which are usually done a few days later. We did not see any increase in need for amputation or future muscle necrosis with the use of prophylactic fasciotomies. So, you know, I do think there are indications for prophylactic fasciotomies. I certainly, anytime I would place a shunt, you know, I think that patient is, for damage control reasons, that patient is critically injured. The last thing you want is your outflow to be obstructed. So I would place a shunt in that instance, probably, I would do fasciotomies in that instance, probably anytime I place an arterial shunt. Concomitant vein and artery injuries, I don't think are necessarily an automatic indication. And same with ischemia time. we've really sort of pushed the envelope on each of those. So
Excellent.
hopefully to come.
Mark, Dr. Kim asked, can you comment on, the concept of hard signs of ischemic injury versus hard signs of exsanguinating injury, and the role for, CTA even in the presence of some traditional hard signs?
Yep, this is another area of active investigation by Joe DeBose specifically, who has published, I think, 3 or 4 papers on this topic. And his main hypothesis is that, there are hemorrhagic hard signs and ischemic hard signs. Hemorrhagic hard signs is automatic immediate operation without imaging. Ischemic hard signs, there is that time to get CTA imaging if need be. So, I think, again, that is a way to the future. I think that opens the doors for possible endovascular therapies and things like that. We've all had many circumstances where a limb had decreased pulses or was even pulseless due to vasospasm and had negative explorations as a result.
Excellent. Any other questions? I mean, I guess feel free and unmute your mic or use the little icon to raise your hand or something. We're happy to take some other questions, I think. Mark, if there's none other, how about antiplatelet agents after you do an arterial repair? You have an 18-year-old with beautiful blood vessels, but Mark Seamon has put a bunch of sutures in the vessel. Is that something that merits aspirin?
Yeah, absolutely. We had that exact patient scenario last week, and he will, we explained to him, we will be on lifelong aspirin now. He had an interposition graft that we got a baseline duplex ultrasound before leaving. He'll get another one at 30 days, another one at 3 months, another one at 6 months, and then yearly thereafter, hopefully.
Excellent. Final question, I guess, if no one else has any. How about choice of conduit for arterial repair? Are you beholden to using saphenous vein, or is there a role to thank our Gore colleagues in Wilmington, Delaware, and use some Gore-Tex or something like that? What are your thoughts?
Yeah, I think for proximal injuries, by all means, you can use conduits like Gore-Tex, meaning above the elbow, above the knee. Vein is still my first choice. There are other acellular agents such as Humacyte, a trial that we're involved in, that might be the way to the future, but they aren't on the market yet. So that's another possibility down the road.
All right, sounds good. Well, listen, I want to thank Dr. Seamon again. Thank you all for attending. Our May lecture is going to be on a 2022 update in ECMO. We'll send out notifications through social media. Hope many of you can attend that. And in the meantime, I'll sit with Jasmine Mann and we'll figure out what happened to the chat function in Microsoft Teams. We'll get it sorted out. All right, guys, thanks. Thanks again, Mark.
All right, thank you all. Take care.